Testing. Okay. Good morning, everyone. We're just going to jump into the next session. My name is Cornell Gray. I'm one of the social sciences track co-chairs for this year's session, and I have the pleasure of introducing the plenary speaker for the social sciences track. Josephine B. Etowa is a professor of nursing at the Faculty of Health Sciences, University of Ottawa, past OHCN chair in Black Women's HIV Prevention and Care, past Lawyer Da Silva Research Chair in Public Health Nursing, past co-chair, Community Health Nurses National Standards, and past president of Health Association of African Canadians. Known for her leadership in anti-racist and health equity work, Dr. Etowa's research has resulted in seminal contributions to Canadian health policy and bringing racism to the forefront of dialogues. Her anti-racist healthcare practice and co-edited community health nurse, her anti-racist healthcare practice and co-edited community health nursing, a Canadian perspective books are well cited. Her research program includes studies on anti-racism, health equity, HIV/AIDS, perinatal health, nurses' work, life, and public health. Dr. Etowa is also the recent recipient of the Randre National Award for Health Promotion, awarded by the Canadian Public Health Association. And with that, I invite you to welcome Dr. Etowa for her talk this morning.
Thank you for coming in this morning to listen to my talk. I'd like to start by just acknowledging that we're seated in the unceded territories of the indigenous people, and that as a Black woman, I'm committed to standing in solidarity with indigenous people in their journey, the pursuit for truth and reconciliation. And I thank the organizers of CAHR 2024 for giving me the platform to share our work. So I'll be sharing, I have no conflict of interest. And these are the learning objectives for these sessions. In keeping with the principles of, or the theme for this conference, breaking barriers, building bridges to facilitate action, moving research to action in HIV. Even though we've heard so much about these barriers, I still want to emphasize and talk about the barriers because it is important for us to continue to remind ourselves of the complexities of these barriers. And in order for us to design real solutions to these barriers, to build those bridges with the right pillars, we do need to deconstruct and continue to remind ourselves about the complexity in the barriers so that our solutions can be complex and can address them fully. And so African, Caribbean, and Black people, and I use ACB interchangeably with Black. And I like the concept of ACB because it constantly reminds me of the diversity even within the Black population here in Canada. Whether we're talking about Africans from the continent, Black people from the Caribbean, Black people who have lived in Canada for over 400 years, we do have diversity within that group, and I constantly remind myself to ensure that there's inclusion of all aspects of that work. And so without staying too much on this slide, we've been talking about this over the last few days of this conference, that Black Canadians are disproportionately affected. Winston called it the cliched, but that is so true. We see the data there, especially in Ontario, where OHC continues to collect data, not least that acknowledges race and ethnicity as a variable that needs to be constantly looked at. And I also wanted to highlight what we've gone through over the last few years, that truly is a syndemic when we think about how the epidemic of HIV that we're still struggling to address within the Black community now is further compounded by the pandemic of COVID-19. And we saw what those hidden inequities, how they became exposed, and what they actually did to those communities that are still disproportionately affected. So it is so important for us to recognize the issue of HIV and to address it within the syndemic lens, so that we can truly understand that we have multiple issues, whether it's HIV, whether it's COVID-19 pandemic, HIV epidemic. These issues intersect to compound our issues at the biological level, at the population level, whether we're talking as whole communities, but also it affects us in terms of the social context we find ourselves, the social determinants of health. And so it's important that any strategy that we identify, we bring in those pieces together so that we can truly address right from the biological or cellular level, like we just heard in the last presentation, really getting into the cellular level. But it's important to remember how the social context impacts on that cellular level issues that we just studied in the last 45 minutes. The social determinants, I can't continue to talk about barriers without talking about the social determinants. That those multiple historical and present-day factors, such as racism and the social determinants of health, account for some of these inequities we're talking about, and that we must recognize them as interacting with each other. That is, it's endemic when we're talking about HIV, combines, interacts with those issues that creates the vulnerability for HIV. And so how ACB people live and maintain well-being while dealing with the burden of racism, and how the social determinants of health really combine with those issues to compound or amplify the burden of this condition. So whether we're talking about housing, employment, education, issues of gender, we must always think about HIV in those contexts, because these are the contextual vulnerabilities that continue to create the impact, that continue to create these kinds of resistance. We're seeing changes in some communities, but not changes in terms of improvement in HIV care for some communities. And so I want to point to some of the local evidence. I have been lucky to be part of a great team of researchers here in Ontario over the past 15 years to engage in work to look at HIV. And I've been blessed to be the last holder of the OHTN-funded chair in HIV prevention and care for Black women in Ontario. And those opportunities, they have given me that leverage to be able to do research in this area. And I want to just point to some of the work we've done and the cross-cutting theme around this work. And so one of the projects I did when I moved from Nova Scotia, Dalhousie, where I first started my work as a community-based researcher, engaging people in communities to create that transformation we heard so loudly from the opening reception. CREAFE is infant feeding study funded by CHRL to look at the sociocultural context of infant feeding among Black women living with HIV in 3 countries. Ottawa was the Canadian site. We looked at in Port Harcourt in Nigeria, Miami in the US. And I would say that project really opened my eyes in all of these 3 countries. It's led to other projects and work, including a World Bank project in Nigeria that has led to the development of a PhD program in midwifery and in nursing in that university. And I continue to work closely with that university to support and supervise students in the program. We also have the We Speak study that my colleague, Dr. Isaac Lugenia from Western University spoke about yesterday during his plenary talk. Again, I was the co-PI for the Ottawa site of that study, and we learned so much about Black men's vulnerability and resilience in terms of responding to HIV programming. And we've also done the study looking, and that particular study was led by Josephine Wong and Dr. Winston Husband, who were the co-principal, they nominated principal investigators. And then we have the AC study that also looked at monitoring and surveillance in the Black community here in Ontario. I was a co-lead for that. One of the projects was funded by CHRL, and Lawrence Mbwagwa from McMaster was the nominated PI for that aspect. OHDN funded the first part of that study, so there were two projects in one. And then over the last 4 years, my research chair funded by the OHDN treatment net, OHDN, has been another opportunity in each of these projects. And then the final project that I would also touch on in my talk is what we nickname CAHR, Canadians of African Descent Women, HIV Treatment and Care, which is literally phase 2 of the OHDN funded chair, moving that research across Ontario to implement a peer equity navigation program to address the issues we found on phase 1. Phase 1 findings, we did a systematic literature review. We're presenting that through our poster presentation. We also did a survey of providers, asking them what they need, what tools they need to be able to work effectively with ACB community people. And we surveyed over 900 healthcare providers, over 400 physicians, over 300 nurses, social workers, about 172, and other service providers, including community health workers and developers. In each of these studies, I just want to point to some of our cross-cutting themes, which I would describe as barriers that come across through this. Racism is a key one. Another key one is knowledge, both the knowledge of providers and the knowledge of community members. We've heard some of these. Communication, public health messaging, how we package this information. What are some of the knowledge translation tools that we're developing? How does that truly convey the message to community members to become advocates for themselves? And even the data that we collect, what's the access to that data for community members to use as their advocacy tools? Do we partner with community only as data collectors, as people to help us with recruitment, so that at the end of the day, they have to go to a particular institution to get permission to access this data when they actually need tools to use? So access was also a key aspect and a barrier. Access in terms of physical location of facilities, but also access in terms of the cultural competence and safety of providers to work effectively. Access in terms of anti-Black racism. How are providers using the knowledge we're generating to truly work effectively with racialized people, especially ACB people? And then agency. We also heard in our studies that while ACB people may have the agency, the resources to transcend adversity, quite often they do not have the opportunity to be at the decision-making table. They do not have the opportunity to be at leadership table, to use that agency, to use the resources that they have to contribute. We saw some of these resources, especially during the COVID-19 pandemic, when community leaders came up. They initiated interventions across the country to begin to address these issues in the community, even before funding was provided. And so these are cross-cutting themes there are barriers. And in order for us to build bridges, in order for us to break these barriers, we need to understand them and make sure that the bridges we're building can actually address these issues. And so, so what? For us, in my lab and the team of researchers I've been blessed to work with, we look at these issues as two folds. One is the system-facing interventions that provide providers, decision makers, the tools they need to understand ACB women's issues, to understand how to work effectively with ACB women, and to understand that HIV exists in the context of many factors that creates this vulnerability. Racism, structural racism, is a key determinant, and we cannot address HIV alone without those factors. And when I talk about structural racism, I actually do not just refer to the systemic level. I refer to all levels. The interaction that happens at the interpersonal level is key, even to the woman coming back to the health facility or seeking health promotion information. The things that happen in institutional or at the community level, it's also very important. And so I see structural racism as those ligaments that hold all levels together, the ligaments that connect our interpersonal racism to the system, to institutional racism and system-level racism, where whole system, whether it's the health system or the educational system, are all affected. And so our intervention must target the system in terms of addressing this level, but also must target the community in terms of addressing these levels of issues. And so I like this diagram. It's not my diagram. I got it from one of the articles we reviewed during our systematic review that really situates racism as core, as foundation to the many manifestations we see, whether it's the social factors, socioeconomic factors that we see as risk factors for HIV, or whether they are the psychological factors, the mental health and other issues that we see as some of those clinical manifestations, but also the biological aspect, like we just learned so much about the cellular level and what happens there. So all of these have to be situated in a way that we understand the underlying root causes of some of the things that those that have been rendered vulnerable find themselves in. And so when we talk about policy, we must also weave in those interventions, whether it's in the way we design our project, in the purpose, the people we target, it has to get into the different levels of this issue. And so actually, my team at the University of Ottawa just released a critical health and racial literacy program for providers. That was on April 2nd that we launched that initiative. It's funded by CIHR, and it's basically an educational tool, modules that are offered online, and we also have webinars. So both synchronous and asynchronous programming is being offered. I do have some cards here. You can scan this QR code to take that program, or you can just see us online. The second aspect of that, which is this different study, 5-year study, looking at community-facing intervention, is the Peer Equity Navigation Program. And I know through posters and some of the comments I've heard here, the central role that peer-led module has in terms of reaching those difficult to reach areas of our community. And so when we talk about peer community leadership, CBPR, community-based participatory research, is a key aspect. Over the last 25 years, I've used it in almost every project that I've engaged in, and I have seen transformation happen before my eyes, whether it's people just coming into the lab to work as research coordinator, and then they leave. They want to do great things. I have people who have been research coordinators in the lab, running for offices, running to be city councillor in Ottawa, or going back to school. I have one of the research coordinator, Calloway, right here. He's a PhD student, has just deposited his PhD thesis ready for defense. He started as a research coordinator in the lab. And many people that just take on different roles when you engage them in learning through these experiences. And so I can't overemphasize the importance of engaging in this community, meaningful engagement with community, to do research with the community. And CBPR is not just an approach to investigation. It is a means to educate and to mobilize for that collective change. I see people engage in this kind of work in the lab. They leave and they want to do more things. Even when they are not working in healthcare. I've seen a PhD student in law who was one of our peer equity or one of our research associates, and still continues to be involved with community organizations to address these health issues. And so, critical to CBPR's work is Paulo Freire's from Brazil, the educator who talks about, who published The Pedagogy of the Oppressed. Because when we talk about education, it's not just a simple process of what we teach. It's also how we teach and engage in this work. That is what creates the transformation we're talking about. And so we cannot see peers as only people that carry out certain tasks in a research team. There are people that are the experts of their own experiences. And if we recognize them as the experts of their own indigenous knowledge, you begin to see that openness, and we give them more tools. And that's what's innovative about our PENS program, giving them evidence-based tool, real-time evidence. As we collect them, they are exposed to it and using it in their own work as well. And so, according to Paulo Freire's work, the critical consciousness raising of constantly educating people, the team members you're working with, right from the proposal development stage where we define and refine the research questions and objectives together, there is an education that happens. I see people think, wow, so these issues affect us this way. I remember one of our projects, the infant feeding study we nicknamed CREAVE. We were returning from Toronto to Ottawa for one of our HIV meetings, and one of the people at the airport, as we were waiting for our flight, came to me and started a conversation about real issues happening in terms of closet breastfeeding and other issues in our community. And said, something needs to happen, she said. I said, how big is this issue? She said, it's a real problem, it's affecting people. That was the beginning. A seed was planted about the project. I got home, I started doing quick search on the literature to see how exactly, how important this is. I held a focus group, invited some researchers locally for us to meet with a group of Black women to talk about this issue. We realized it was an important issue, and that's how we engage in the 3-country study that has led to activities and different growth, both in the US, in Nigeria, and also here in Ottawa. So it starts from the community. And so if you see an issue, analyze the situation. You then act on it. We cannot wait for other people to act on these issues. We must be prepared and given the tools, and I say we meaning Black women, to engage in this work ourselves. And this is the kind of work that, the framework that informs the work that our peer equity navigators do. This is a diagram actually developed by our team during the AC study that really captures that process in summary. You can see here that the community is placed at the center of the work we do, right from the beginning of the project. The community is at the center as we pulled different organizations together, whether they are aid service organizations, academic institutions, community health centers, coming together to work together to co-design and implement projects. And it is through this process that as a team we work together And when we get the findings, again, we bring the community back, whether it's through an action summit, through a World Cafe event, to share the findings and to have that platform serve as a member check for us to have input, wide input from multiple stakeholders before we start our knowledge mobilization activities, which is at this very end here. Knowledge, you can see the different activities, which now includes our critical health and racial literacy training program for providers. The provider module is a 5-module series. The PENS module is a 12-module series. So the peer equity navigation, we've used this module in various formats for our different projects, and during the COVID-19 impact study, it was a national study funded by PHAC, and we saw how these peer associates, we called them at that time, worked so well together. That was part of my motivating factor, to move that into giving them more tools, more training, giving them more evidence to do even more than they did. They were encouraging me because we gave them 12 months. We need over 1,500 ACB people to take part in this survey, and they made that task. They formed their WhatsApp group where they communicated with each other on a daily basis, encouraging each other across the country. We trained about 13 PENs from Newfoundland to Nunavut, across everywhere, and they just communicated with each other and inspired all of us in terms of what needed to be done. And within that 2 months, they were able to get over 1,500 participants to complete the survey. And so this program was then reworked to implement our PHAC-funded vaccine. We call it ACB Vaccine Acceptance Project, which is the AVA ACB PENs. That we really, again, saw these people in action, the peer equity navigators. So who are they? They are community members. They share this common context, norms, and experiences with the population we're trying to reach. Several of the PENs were, for that particular cohort of PENs, they were internationally trained providers who needed some Canadian experience. And they were valued members of our team and brought a lot of different perspectives. The training for these PENs was innovative in terms of how we position the 12 modules that they had to think, starting with the historical context of Black Canadians and moving right through social determinants and population health frameworks, and really getting into race and the many pathways through which race and racism impact on health and HIV in particular. In each of these modules, HIV is a key module. And we do have simulation game. We worked with the Canadian Association of Simulation, and we have simulation scenarios that showcase somebody coming in with HIV diagnosis and how they are interacted. So I encourage many of us as researchers to engage in this. This process also helped me to see that the resilience this group of providers, the peer equity navigators, were building was not just individual. There was collective resilience, that they were working with each other and really talking about how they can move agenda forward. I saw they did not even come to the research team, but they made uniform for themselves. They prepared T-shirts, and they were wearing T-shirts with the peer equity navigation PENs, rewriting the story of health equity for ACB community. They nicknamed them. They came back and told me they were nicknamed in the community as the foot soldiers. The ACB foot soldiers have arrived. They were in malls with their T-shirt, peer equity navigators that are rewriting the story of health equity in Black communities. And so it's been an inspiration even for me to just watch them do some of these things. So again, I say the training covers both, can barely see this, this slide. The training uses both a pedagogical framework in terms of how we teach it, but how what we also teach. But it's also designed in a way that not only the classroom work or the things they are doing online, but they have a practicum. They are placed in organizations across Ottawa when we did it there, and we also have sites now in Toronto, in Windsor. We have partnership with organizations that are also part of the training. With preceptors, they have preceptors that coaches the peer equity navigators in terms of available resources in their local areas, but also partnering with them over the 6 weeks of their preceptor experience to carry out community outreach activities in churches, in different events, venues, and then they take over. As once they finish their preceptor opportunity, they continue to implement some of those community outreach events. We had over 56 events that they offered during the vaccine implementation. And even during that vaccine implementation, we used it as opportunity to teach about HIV, because you will not believe how many people have very limited knowledge about HIV or are still afraid. Even in our survey of healthcare providers, we still see a significant number, over 50% say they are very concerned about exposure to HIV virus. We say that in one of our posters that are there. Even not just physicians or people that are involved in invasive procedures with the public, even social workers express concern about exposure to HIV virus. And so we still have a lot of work to do. This morning during this session, somebody talked about the high turnover in terms of workforce, health workforce. So sometimes we have new people we should continue to teach, because some of the people you taught last year might have left and new people have come in. And so it is so important for us to continue this education. These are some of our PENs. This PEN in particular has now moved on to register into full-time nursing program. So that's what I mean, that engaging in this work changes the way you see the issues and creates motivation to do more. She's now a full-time nursing student in Ottawa, and the second PEN is working on her licensure as a pharmacist in Canada. So they did a lot of activities, as you can see there. Trying to move through these slides quickly because I want to have some question time. These are some of the PENs in action. You can see them in the mall. Oh, no, I meant to go back. You can see them there in the mall, here in somebody's home. They are at different events promoting, again, the work. We've done evaluation of the PENs, and we're using the REAIM framework to do that evaluation. We also have a logic model to do the evaluation. You can see some of the comments there, very positive comments. We did some focus groups with both the PENs and their preceptors, different focus groups to find out how they felt. It was useful, and it's been very positive feedback. We have submitted this paper to a journal. Hopefully we'll get it published soon, and you'll have access to some of this feedback. And so in terms of discussion, I still want to emphasize the need to use this peer module, but not only using the peers as data collectors or as people that can help us with recruitment, or as people that carry only specific tasks that the research team has assigned them, but as people that are capable of taking on a lot more. Because the more information, the more evidence we can put in their hands, the more they can go out there and motivate people. It's not only, I see this as multi-level intervention in that we are educating PENs and we can see the transformation happening at that level. But the PENs are also going into the community and creating a movement and creating people. The whole idea of foot soldiers came from community members. Say, oh, there they come again, the foot soldiers are here. And so I got somebody who called me, not like I said, not in health, but in law, and say, how can I contribute? And this person is serving on one of the local health organization boards, so they can contribute to this work as well. So it is important to continue to work with peers and to see how peers can be seen as one of those key pillars to breaking barriers and one of those key pillars to the bridges that will lead us to action in our HIV research, but also in HIV care as a whole. I'll stop there. Thank you. And these are our partners. I'd like to acknowledge them, various universities that have worked with us to do this work.
Excellent. Thank you, Dr. Etowa. We have some time for questions. There's a mic in the middle of the room if there's anyone interested.
Okay.
Hello.
Hi.
Asya Gundas from the OHDN. Thank you so much. This was very insightful. And I think the Peer Equity Navigators program can be a model for many other things as well. So my question will be, in the context of integrated HIV and anti-racism training and navigation, what are your recommendations for other racialized equity-seeking groups, especially newcomer communities, to learn and act more on anti-Black racism? I'm specifically kind of touching on the anti-Black sentiment in non-ACB newcomer and immigrant groups. I am also the main organizer of the Lubuntu, the LGBTQ newcomers from Turkey, and we have many members from the MENA. So I'm just like curious. And also, what were your challenges in cross-racial peer training and navigation, and how did your team overcome those in the program? Thank you so much.
Thank you. Great question. When I talk about the Critical Health and Racial Literacy Program, I actually see it as a program that can be used beyond the ACB community. I see this as something that involves ACB community members, other people that have been rendered vulnerable because of their race, so the process of racialization, but more importantly, even those that are allies to the cause can take this program and we work together. So everyone can benefit. We have different pathways through which we may learn through the process, how we interact in this, when we find ourselves in cross-racial interaction. In terms of the peer and equity navigation, I think actually one peer that I remember when we did a national study for COVID impact that was non-Black, but was racialized, worked very well, you would not tell actually, like interacted very well and had a great time as a peer equity navigator or a peer associate at that time. So I can see it working. What's the role of immigrants, for example, that are not Black? I think people can play a role as allies in the cause. When we're building capacity for anyone, everyone who is interested in advancing the cause. I have had the opportunity to work over the last 4 years actually with Dr. Goss, who is here with me, as a postdoctoral fellow, not from the ACB community, but we've worked well together addressing these issues because we have a shared interest in advancing health equity and closing that equity gap. So thank you for your question. Okay, I see more questions.
Good morning, everybody. For me, it's not a question. Thank you, Dr. Josephine, for the beautiful presentation. I'm here as a witness. So I come from Toronto. My name is Chantal Mokandoli. I'm working with Women Ahead in Women Ahead Community Center. So I'm here just to talk about there is something I'm not agree with that. You know, talk about HIV is manageable. It's something I cannot, as a leader in the community, to educate other people about that. It's not possible. It's manageable for some of the people, but no for all of us. So other things I hear talk about forgiveness over the treatment. I don't even understand that. Because is a medication who forgive a human, or is a virus who forgive human? So that is not something, maybe, I'm sorry also to say this, forgive me for someone who created this, but it's something, stigma also. For me, I can see stigma in a vision. Huh? So one thing just I want to say, I am a leader in the communities, both languages, English and French. I see we don't have a funding in the communities. I'm lucky to come to these conferences to represent community members, clients, volunteers, peers. Yes, people have experiences of communities. We know each other, even if people need 100 people to participate in the research. Chantal, I'm there to give people information in the community. There is a research. Can you go and participate? And they're asking me the information. Why? What is the important for me to go to participate in that research, Chantal? I need to explain. Because I gained something. I came here to learn. I will go back. I'm not going just sitting down, put all the documentation in the drawer. I will go back and then educate my people. I say in my village, villages means people living with HIV like me. So we need, please, we need funding for the peers.
Yes.
I appreciate Wangari Tarao. She's not here with us. She's the director of program and research. She do the best to make sure Women Hand Community Center have a second hand. Second hand means peer. You are in the office, but you don't know what is going on there, outreach, or sur terrain. Vous ne savez pas ce qui se passe sur terrain. Alors, je crois que vraiment, ça c'est le dernier moment de parler, de donner des commentaires. But we need funding for peers. We are tired to have a token. We need to be paid because it will be like a job. Please, I beg you. Thank you so much.
Thank you, Chantal.
Well, I feel like I'm going to be underwhelming after that. Hi, my name is Zoe. I'm wondering if you could speak a little bit more about your kind of knowledge mobilization events. Obviously, like being Black-led was one of the core things about them, but are there other kind of key things that either brought people in or that you found were really helpful, especially when you're dealing with these often stigmatized topics, to change people's minds, like approaches that you used?
Great question. I think we go for the low-hanging fruit. There are some churches that have supported our work, and so that means going to the faith-based leader and asking them to help us have event. We've had one of our faith-based leader post things on Facebook to encourage people. He's actually one time reached out to me and said, please, when you come to the church, can you not start with HIV? Start with the problems in our community, and that has worked. I go in, I start talking about the problem facing Black people in terms of health, and we build the case about how social determinants affect us, and one of the areas that is highly impacted is HIV. Then they're already listening. and we start talking about HIV. It's interesting because years ago, that was exactly how I did workshops on racism. If I say we're doing workshop on racism, none of my colleagues wants to come to this. If I say we're doing cultural competence, they showed up, then we talk about power dynamics and racism. I have to use the same strategy sometime when I'm talking about HIV. Start with the social determinants of health. Start with the social cultural context. Bring in how that then affects us, including HIV. I think some of those work, but also the use of the peers. The peers have the network, and so we're going with the peers. We have people who are from the Muslim community who would take us to the mosque, and so I'm going in there because I know people in the church. We're going to a Francophone community because I have people there who are very fluent in the language, who are from the community, and so I accompany them. We go to a hairdressing salon or barber shop because there's somebody who maybe uses that barber shop and has invited us. So using the peers and people who have the connections and network has been key to reaching these areas.
Thank you.
You're welcome. Oh, okay.
Right, thank you so much. With that, the Q&A session is closed for today. On behalf of CAHR and the Scientific Committee, I'd just like to present this gift to Dr. Etowa for an amazing talk and for agreeing to be our plenary speaker.
Thank you. I can get a picture. Thank you. Yeah.
All right, so I think we have about 15 minutes before the next set of sessions, so thank you.